Hi all. Anatomy Basic Sciences Part 4. Palatine tonsils, which is an nasopharyngeal tonsil, adenoid, and lingual tonsil constitute a major part of alveoli or mucosa-associated lymphatic tissue. When the tubal tonsils and lateral pharyngeal bands has less prominent component. A ring composed of nasal associated lymphatic tissue at the beginning of the foot and hair passage, which will produces B and T lymphocyte, which act as local defense mechanism. They also produce lymphocytes to send to other lymph nodes. So the very important question is tongue muscles. I wanted to remember 5 important key points with respect to the tongue muscles. First, the tongue muscles are divided into extrinsic, intrinsic group of muscles. Extrinsic is genioglossus, hyoglossus, styloglossus, and palatoglossus. Intrinsic is superior longitudinal, inferior longitudinal, and transverse muscles and vertical muscles. So the one point I wanted to remember is all muscles are supplied by hypoglossal nerve except palatoglossus, cranial part of accessory nerve. So the one point I wanted to remember here is genioglossus from genial tubercle, that is from the chin to the tongue. Hyoglossus from the hyoid bone to the tongue. Styloglossus from styloid process to the tongue, and palatoglossus from the palate to the tongue. So if this muscle, if it contract, it will protrude the tongue. This is the safety muscle of the tongue. Styloglossus, here if it contract, it will retract the tongue. Hyoglossus, if it contract, it will depress the tongue. Palatoglossus, if it contract, it will elevate the tongue. And the intrinsic muscles of the tongue, which are nothing but superior longitudinal, inferior longitudinal, transverse, and the vertical muscles. Superior and inferior longitudinal, both these muscles. These longitudinal group of muscles. So remember the mnemonic. Longitudinal group of muscles will shorten the tongue. In such cases, superior elevates, inferior depress and shortens the tongue. Transverse group of muscles. So here there is a transverse group of muscle. If it contracts, the tongue will become narrow and it will elongate. Vertical group of muscle. If it contract, it will flattens the tongue, and now it will elongate. So this is very important one. And blood supply of tongue is mainly from the lingual artery, which is a branch of external carotid artery. And with respect to the sensations, sensory branch anterior to third, general sensation is by the mandibular division of trigeminal nerve via the lingual nerve. Special sensation, taste sensation via the facial nerve fibers, which is superficial. Special visceral afferent, SPAT NTS fibers, chorda tympani, and posterior 1/3 fiber, pharyngeal arch, which gives general and special sensation via the glossopharyngeal nerve. So if we divide the tongue, it's mainly based on the occipital myotomes. Anterior 2/3 of the tongue is mainly V3, mandibular division of trigeminal nerve, and posterior 1/3 of the tongue is mainly by the glossopharyngeal nerve, 9th nerve. The posterior most portion is the so the anterior 2/3 taste sensation is mainly by the chorda tympani, whereas posterior 1/3 both taste sensation and general sensation is mainly by the glossopharyngeal nerve fibers. So what are all the layers of the skin. So we know epidermis, dermis and hypodermis. I want you to remember 3 important points: B, S, G and C. Basal, spinosum, granulosum, lucidum, corneum. Stratum corneum, keratinization. Basal, keratinocytes and melanocytes produces. From there, the migration of the cells from stratum basal layer to stratum corneum layer. The nutrition supply or the blood supply to epidermis is derived by the passive diffusion of the nutrients and oxygen from the dermis to epidermis. As you see, the blood vessels present only in the dermis layer and hypodermis layer, not in the epidermis layer. So the passive diffusion of the nutrients from dermis to epidermis, that's how oxygen and nutrients reaches the skin. So sometime they may ask you about flexor retinaculum. So just remember this point. The transverse section through the corpus showing the attachments and relations of the flexor retinaculum. So here it is ulnar bursa, which is enclosing the FDP and the FDS tendons, whereas the radial bursa, which encloses the FPL, flexor pollicis longus. The main trunk of the median nerve lies beneath the flexor retinaculum, and this is a carpal tunnel, whereas the palmar cutaneous branch of ulnar nerve and median nerve lies above the flexor retinaculum. So in case of carpal tunnel syndrome, the sensory innervation is spared, whereas the motor innervation is affected, and this is a volar carpal ligament, ulnar nerve and ulnar artery present in the Guyon's canal. So this is Guyon's canal, which is formed medially by the hypothenar muscles and volar carpal ligament and flexor retinaculum. Clinical significance: carpal tunnel syndrome. They will release the flexor retinaculum so as to prevent the entrapment of the median nerve. So sometimes they may ask you about popliteal fossa. Popliteal fossa, in the sense which is semimembranosus, semitendinosus, is bounded supromedially, laterally by the biceps femoris, infrolaterally by the lateral head of gastrocnemius, infromedially by the medial end of gastrocnemius muscle. So the outline of popliteal fossa: posterior cutaneous nerve of the contents, posterior cutaneous nerve of thigh, lateral cutaneous nerve of calf, peroneal communicating nerve, small saphenous vein, and posterior division of medial cutaneous nerve of thigh. The floor of the popliteal fossa is formed from above downwards by the popliteal surface of the femur, the capsule of the knee joint, and the oblique popliteal ligament, the strong popliteal fascia covering the popliteus muscle. A very important question they may ask you about thoracic duct. It's an internal iliac lymphatic trunk and the external iliac lymphatic trunk on both sides that joins to form the common iliac lymphatic trunk, the lumbar lymphatic trunk. Then they will joins to form from the right and left to form the cisterna caeli, and from there descending thoracic lymph trunk drains into the cisterna caeli, and thoracic duct ascends up, and they will enter via the T12 opening in the diaphragm. From right to left, they will cross over at the level of T4 to T5, and then right bronchomediastinal lymphatic trunk and left bronchomediastinal lymphatic trunk. They all join brain. Right bronchomediastinal lymphatic trunk and the right lymphatic duct drains into SVC, and from the left side they drains into the left SVC, and they drains into the thoracic duct. So the very important thing is thoracic duct goes in essence through the posterior mediastinum from the right side to the left side on the level of T5. In the neck it arches laterally on the level of C7 vertebra and descends in front of the first part of the left subclavian artery, ends by opening into the angle of junction between the left subclavian and the left internal jugular vein. So relations, as I already said, T12 opening, posterior vertebral column, anterior diaphragm, to the right acetabular vein and to the left aorta. And in the posterior mediastinum, anteriorly diaphragm, esophagus, and the right pleural recess. Posteriorly vertebral column, right posterior intercostal artery, and terminal part of hemiacegus veins. To the right there will be acegus vein. To the left there will be a descending thoracic aorta, a very important anatomical landmark. Clinical significance. Virchow's note. Virchow's note, I separately made a video in anatomy basic sciences, just look into that. So Virchow's note drains into thoracic duct via the left jugular lymphatic trunk. Due to the difference in the phasic respiration pressure, there will be regurgitation of the metastatic tumor deposits from the thoracic duct via the left jugular lymphatic trunk. Then it will enter the supraclavicular lymph node. From there it will form Virchow's node, which lies between the two ends of sternocleidomastoid muscle. So the very important is they may ask you the question with respect to the ischial fossa. Just remember this anatomy. Longitudinal muscle coat of the rectum and the circular muscle is present in the side, and longitudinal muscle coat of the rectum, which is traversing the external anal sphincter, and then it will opens into the skin. The internal anal sphincter is formed by the circular muscle coat of the rectum, and these muscles are arising from the tinea coli. Tinea coli is absent in the rectum till sigmoid colon. Tinea coli is present. The tinea coli is converted into circular and longitudinal muscle coats, and then it will support the rectum on its lateral wall. And there will be ischiorectal space which is present on the either side of the anal canal, and it is filled with fat. Pudendal canal, which lies at the floor of the ischiorectal space, which mainly contain pudendal vessels. So this very important is these two ligaments. The inferior fascia of pelvic diaphragm will form the roof of ischial fossa. So the content of ischial fossa, ischiorectal pad of fat, inferior rectal nerves and vessels, just S2, S3, S4 root value, pudendal canal along with its contents, posterior scrotal or posterior labial nerves and vessels, perennial branch of fourth sacral nerve S4, and perforating cutaneous branches of S2 and S3, and this is a very important anatomical landmark. So this is the surface view of ischiorectal fossa showing its contents. So this is internal anal sphincter, levator ani group of muscle, and the ischial fossa and its contents. So a sacrotuberous ligament which forms the boundary, and the perforating nerves, perennial branch of S4, the inferior rectal vessels and nerves, and posterior scrotal nerves and vessels will be present.